Hello, everyone, and welcome to the Minnesota Department of Health monthly stroke education series. This month, we are going to be covering the topic of stroke severity tools in the pre-hospital setting. My name is Katherine Johnson, and I am the EMS coordinator for the stroke team. Thank you for joining us today. As usual, your lines have been muted upon entry to this webinar. Please ask questions by typing them throughout the presentation in the chat bar. Please select everyone. We will keep track of these questions and we'll try to address them at the end of the presentation or within the webinar follow-up email. Excuse me, before we get started, we just have a couple of quick program updates from our team. Our first update is we will be launching the third year of our Hospital Quality Improvement Awards coming within the next several weeks. Look for an announcement from Allie, our QI coordinator. We will also be starting our first year of Quality Improvement Awards for EMS agencies. Details regarding the EMS awards will be coming from me in the next few weeks. The last update is just a reminder that the deadline for the next designation cycle is April 1st. By the end of this presentation, we hope that you will be able to list 2 or more stroke severity tools for pre-hospital providers, describe the need for implementing a stroke severity tool, and compare 3 stroke severity scales based on signs and symptoms evaluated in each scale. Today, we are going to be discussing the history behind the need for stroke severity tools. We will briefly cover the stroke scales FAST-ED, RACE, VAN, CSTAT, LAMS, PASS, and LARIO, as listed on the screen. This webinar is meant to be a high-level overview of the scales in order to help agencies choose a scale if they have not already implemented one. We will talk about the challenges and issues regarding stroke scales and hopefully answer any questions you may have. So let's get started. Before we cover the different stroke severity scales, we need some history on how these stroke scales came about. It started in 2015 when studies revealed that endovascular therapy was beneficial in stroke patients within 6 hours of onset of symptoms. In 2018, the American Heart Association published guidelines for the early management of patients with acute ischemic stroke. They provided guidance from the DAWN and DIFFUSE 3 trials, which suggested that some patients could benefit from an expanded treatment window of thrombolytic therapy from between 6 and 24 hours. This expanded time window meant that there was an option for treating patients who were outside the 4.5-hour time window for TPA and increased hope for some recovery for those patients previously considered too late. This also meant for EMS agencies, who often are a stroke patient's first point of contact with the healthcare system, had transport decisions to make on which facility could best treat their patient. As the use of endovascular therapy continued to expand, it became the standard of care for large vessel anterior ischemic strokes, and still is today. And rapid transport by EMS agencies to an endovascular thrombectomy capable center is a patient's best option to receive this specialized care. In 2019, an update to the 2018 guidelines was published. This update provided 2 new recommendations for EMS agencies. These recommendations included bypassing an IV alteplase capable hospital if the hospital that provides a higher level of stroke care is less than 15 additional minutes away, in accordance with their new Mission Lifeline severity-based stroke triage algorithm for EMS. It also recommended that EMS have procedures to identify patients who have a strong probability of a large vessel occlusion and prioritize those patients to a thrombectomy-capable facility. They noted that modifying the Mission Lifeline algorithm based on regional factors, including the availability of endovascular centers, door in and door out times for non-endovascular stroke centers, interhospital transport times, and door to needle and door to puncture times. This recommendation of transporting patients an additional 15 minutes came with a lot of concern for the more urban EMS, but left a lot of the rural agencies out of the loop, as most often they do not have a thrombectomy capable stroke center within an extra 15 minutes. The AHA update also recommended an quote, effective pre-hospital procedure to identify patients who are ineligible for IV thrombolysis and have strong probability of large vessel occlusion should be developed to facilitate rapid transport of patients potentially eligible for thrombectomy to the closest healthcare facilities that are able to perform mechanical thrombectomy. This recommendation does not specify this for only urban areas that can access a thrombectomy capable facility quickly, but recommends it for all agencies. Even in rural areas, notifying your facility that you have a suspected large vessel occlusion stroke could decrease the time spent in their facility and help expedite the transfer to a facility with thrombectomy capabilities. In 2021, this consensus statement was released to help guide the agencies in all geographic regions on creating their own stroke system of care. It was a follow-up to the 2019 recommendations. And in the statement, they say, quote, while this was reasonable for urban areas with multiple nearby hospitals, more explicit guidance for how to modify these approaches for suburban and rural environments was urgently needed. And this consensus document was an effort to address that need, unquote. The statement also gives quality improvement or performance measures to assess, gives recommendations for stroke systems of care based on geography, and heavily recommends the integration of a stroke severity tool into protocols for all EMS agencies, regardless of location. It also contains an updated Mission Lifeline stroke transport flowchart. If you have not had a chance to read this recommendation, we highly encourage it. This updated routing chart provides guidance to agencies on when to transport to a comprehensive stroke center. Based on a validated stroke severity tool, their last known well time, and if the transport time will not disqualify the patient from receiving thrombolytic therapy, they should transport to the nearest comprehensive stroke center or thrombectomy capable stroke center. It also advises them that if any of these should disqualify them from receiving thrombolytics, or if the transport is greater than 30 minutes total, that they should transport to the nearest acute stroke ready hospital and provide pre-notification. Providing pre-notification of a possible large vessel occlusion stroke to the acute stroke ready hospital will allow them to start their stroke code process, hopefully decreasing their time to timely treatment. I will give you a few moments to look at the flow chart. In an effort to provide some assistance in adoption of stroke severity scales, we have created two documents for agencies. They are currently in draft form, and we are seeking input from hospital stroke treatment centers and from EMS medical director leadership. We are also seeking AHA endorsement at this point. The first is a best practice statement, which provides the background of stroke severity scales and the evolution of endovascular therapy as a standard of care for large vessel occlusions. The second is a document of the best practice strategies, which outlines recommendations for quality stroke care, including the implementation of a stroke severity scale. We don't have guidance on which tool to use at this time. We believe it to be an individual agency decision based on their medical director and local hospital choice. EMS agencies and hospitals working together on the protocol and notification give the patient the best chance for quality recovery. Once input has been received and any changes that need to be made have been done, these documents will be available to everyone. Our best practice strategies document also contains our routing flowchart, which is very similar to the AHA Mission Lifeline stroke, but is tailored for our state in adding the fact that we have thrombectomy capable stroke centers in this state. Just like the AHA flowchart, we also do not recommend bypassing your local facility if it will cause a transport time over 30 minutes or the amount of time will disqualify the patient for thrombolytics. I will also give you just a few seconds to look at this chart as well. Now that we've covered a little bit of the history of the stroke severity scale recommended use, let's get into the scales themselves. As many of you know, the gold standard for assessing stroke severity is the NIH stroke scale. It measures 11 different areas for stroke in a scale of 0 to 1 or 4. However, this scale is difficult and time-consuming to perform, especially in the field of EMS. It is also very difficult to train on and to perform properly, even by experienced providers in the hospital, and may be extremely difficult for providers to keep up their skills. Therefore, the goal has been to come up with a scale that is both easy to perform in the field and accurate at detecting large vessel occlusions. The first scale we are going to talk about is the Field Assessment Stroke Triage for Emergency Destination, otherwise known as FAST-ED. This scale, along with several other scales, is validated by the American Heart Association. This scale measures facial palsy, arm weakness, speech changes, eye deviation, denial, or neglect. Each category is measured on a 0 to 1 or 2 scale based on absent, mild, or severe symptoms, and the total is summed into a predictive value is given. In this diagram, you see there is also the comparison to the National Institutes of Health stroke scale so that you can see how they compare. A systematic review published in the 2019 in BMC Emergency Medicine found that the sensitivity of this scale to be 71%, with a specificity of 78%, and a positive predictive value at 62%. This scale is currently being used by some Minnesota EMS agencies already. Just a quick reminder for those who may not recall, sensitivity is the test's ability to identify a person who is having a large vessel occlusion stroke, whereas specificity is the ability of a test to determine who is not having a large vessel occlusion stroke. And positive predictive value is the ratio of patients truly found to be having a large vessel occlusion stroke to all of those who initially tested positive. So in this scale, the scale's ability for the detect a person who is having a large vessel occlusion stroke is 71%. The ability to determine if they are not having a large vessel occlusion stroke is 78%, and the ability to detect who is truly having a large vessel occlusion from those who initially tested positive was 62%. This scale can be said to be fairly precise at detecting large vessel occlusion strokes. The next scale we're going to look at is the Rapid Arterial Occlusion Evaluation Scale, also known as RACE. In this scale, facial palsy, arm drift, leg drift, gaze deviation, aphasia, and agnosia are all measured on a scale of either 0 to 1 or 2 as well, based on their mild or moderate in severity. The scales are then totaled on a 0 to 9, with the higher the number, the more likely the large vessel occlusion is present. This diagram also shows a comparison to the NIH stroke scale. According to the same systematic review, it found that the sensitivity of RACE to be 74%, with a specificity of 80% and a positive predictive value of 85%. As you can see, the scale was found to be very sensitive and specific, and also had a high positive predictive value, showing that the scale also be fairly accurate at detecting large vessel occlusion strokes. We also know that this scale is being used by some Minnesota EMS agencies as well. The next scale we're going to talk about is currently being used in Minnesota, and it is the Stroke VAN scale, which stands for vision, aphasia, neglect. The scale itself measures arm drift, visual disturbance, aphasia, and neglect. The key to the VAN scale is that the patient must have arm drift before proceeding with the rest of the scale. As you move on with the scale, similar to the Cincinnati stroke scale, it is either positive or negative for large vessel occlusion. There is no math or checklist to perform. The sensitivity, according to the same study, is said to be 95%. However, the specificity is only 56%, with a positive predictive value of 23%. The scale is fast for providers to perform, but may need some further study as to its accuracy as predicting large vessel occlusions. Another point-based scale is the Cincinnati Pre-Hospital Stroke Scale, also known as CSTAT. The Cincinnati Pre-Hospital Stroke Severity Scale, also known as CSTAT. The scale measures gaze, level of consciousness, response to commands, arm drift, and is given points for each assessment. Sensitivity is said to be 54% with a specificity of 91% and a positive predictive value of 45%. Many EMS agencies currently use the Cincinnati Pre-Hospital Stroke Scale for their initial diagnosis of stroke, so this scale may be an easy adoption for them if the agency so chooses. That scale measures facial droop, arm drift, and speech. So this would be an addition onto that scale after that scale has been determined to be positive. This test isn't as sensitive or specific as the first couple of scales, but is accurate at ruling out a patient not having a large vessel occlusion stroke. The Los Angeles Motor Scale, also known as LAMS, is another fast tool for measuring stroke severity. It measures facial smile, grip, and arm weakness on a scale of 0 to 2. Facial smile is assessed for the presence of droop. Grip can be normal, weak, or absent, and arm weakness can be normal, drifts down, or falls rapidly. A score of 4 or higher is strongly indicative of a large vessel occlusion stroke. According to the systematic review in BMC Emergency Medicine, the sensitivity ranges from 57 to 94%. The specificity ranges from 74 to 85%, and a positive predictive value from 28 to 66%. The variability in these results needs to be looked at further to determine if this tests reliability. We have two more scales we are going to look at. The first being a pre-hospital acute stroke scale, otherwise known as PASS. This scale measures level of consciousness, gaze, and arm weakness. PASS measures whether they are present or not only. The sensitivity is said to be 69%, specificity of 85%, and a positive predictive value of 40%. There's another version of the scale called the MPASS, which adds aphasia and dysarthria to it. In a study published just back in July of last year, it showed a specificity of 84%. The final stroke severity scale that we're going to look at is a fairly new one. It is called the Large Artery Intracranial Occlusion Stroke Scale, or LARIO. The scale measures facial palsy, arm weakness, grip strength, language or aphasia, and neglect. The scale is a strictly 0 or 1 score, and the higher the number the sum, the more likely a large vessel occlusion is present. This scale is not included in the systematic review, but in one study found the confidence interval to be 90 to 98% and a positive predictive value of 77%. With a positive predictive value that high, this may be a good option for agencies. So to summarize the different scales, I created this chart which shows what each scale measures. As you can see, arm weakness is measured in every single scale we looked at. Facial palsy, eye deviation, and neglect are also common indicators assessed in the stroke severity scales. But just like the large vessel occlusions that can be hard to diagnose themselves, coming up with a consensus scale has also been difficult. So now that we know that there's a large handful of scales, you can see why picking one may be difficult. The ones presented today were only a handful of scales. There are numerous available. We need a scale that sufficiently identifies large vessel occlusions without overactivating a stroke team. We know that some false activations are going to happen, but it can't be excessive. We need one that's easy enough for EMS providers to be trained on, but not overly simple that it doesn't do its job. And what signs and symptoms must be included hasn't been determined by national consensus, as we saw in the chart on the previous slide. In an attempt to assist with choosing a scale, the American Heart Association has many great resources, one of which is this pamphlet, which contains CSTAT, RACE, FAST-TD, NIH, and LAM stroke severity scales. I will include a link to this brochure in my follow-up email after the conclusion of this webinar. The AHA does not advise one tool over another. Rather, that recommends that you work with your agency and hospital to decide what works best for your area. If your hospital or agency is looking for a systematic review to compare these scales, this research article has been extremely helpful. It looked at studies with 300 or more patients published between 2015 and 2018. The results of this study showed that the results of this study showed that, quote, assessment of both cortical and motor function using RACE, FAST-ED, and NIH showed the best diagnostic accuracy for selecting subjects with LVO, unquote. Well, that is the conclusion of this article. It also provided an extremely beneficial chart comparing the sensitivity, specificity, and positive predictive values for most of the scales covered today. The article may help you compare which scale might work well for your agency. Here is the list of references used in this presentation. They will also be sent out with a copy of the presentation following the end of this presentation. I will also send out a link to that AHA pamphlet mentioned earlier. Are there any questions? Please use the chat feature to type in your questions or press *6 to unmute your line. Any questions? All right, the link to the survey will be placed in the chat. Remember to click on that chat bubble in order to view the chat box. One question that just came in your work, do you see the Cincinnati stroke scale as outdated? The Cincinnati stroke scale in general is a good tool for diagnosing strokes initially, but however, with large vessel occlusion stroke, obviously something else needs to be added. Hopefully, they will eventually come up with tools that incorporate it all in one, but it seems to be pretty piecemeal at this moment. And by saying that there's a lot of stroke scales, there are a lot. When doing this research, it was more of the reducing the number so that we didn't overwhelm you with the amount that are out there. Not seeing any other questions, that's all we have for today. I really hope that this provided you with some general overview, and hopefully it will assist you in helping to choose a scale for your agency or encouraging your agency to adopt a scale. Please join us next month for our next monthly education offering. We will send out more information as the date comes closer. I'll give you a few minutes back in your day and stay well and take care.